Thank you. I want to first welcome everybody that's here in South Florida that's at this program today. What do we hear from you all? Good morning. Our sponsor, our gold sponsors were EMD, Serono, and Sandoz. Our silver sponsor was Bristol-Myers Squibb. Our bronze supporters, Memorial Healthcare System, Sanofi, and Viatris. Our community sponsors, Mallinckrodt, Alexion Pharmaceuticals, and TG Therapeutics. And our exhibit sponsors, FlowMed Infusions, Genentech, First Choice Neurology, and Novartis. And let's give them a round of applause for being here to do this program today. Thank you. So Dr. Boster is a board-certified neurologist specializing in multiple sclerosis and related CNS inflammatory disorders. He decided to become an MS doctor at the age of 12 as he watched his uncle Mark suffer from the disease in an era before treatment was even available. Dr. Boster grew up in Columbus, Ohio, and attended undergraduate at Oberlin College. He earned his MD at the University of Cincinnati College of Medicine and completed an internship in internal medicine residency in neurology at the University of Michigan. He then completed a 2-year fellowship in clinical neuroimmunology at Wayne State University. Since then, Dr. Boster has been intimately involved in the care of people impacted by MS. He has been a principal investigator in numerous clinical trials, trained multiple sclerosis MS doctors and nurse practitioners, published extensively in medical journals. He lectures to both patients and providers worldwide with a mission to educate, energize, and empower people affected by MS. Now, you don't see the doctor because he's not here. He's going to be online.
Good evening, and thank you for having me out. Thank you, Stuart, and thank you to MS Views and News for this opportunity. Hello, everyone on the interwebs, and hello, everyone. I'm sorry I can't be there in person. I'm grateful for the technology to let me connect with you guys. And today, I'm going to be talking to you about the power of the patient. And one of the ways that I think it's imperative that you take MS into your own hands and take control over your disease process. This is my disclosures. If you're a plant from the American FDA, what are you doing hanging out at our patient program? I also will admit that I have shamelessly stolen slides to make this presentation today. In order to understand multiple sclerosis, we have to start by understanding the immune system. So we have lots of systems in our body. The cardiovascular system pumps blood throughout our body. The pulmonary system sucks in oxygen and blows out carbon dioxide. The immune system is the part of the body that fights off bad guys. So when you come in contact with a virus, with a bacteria, with a fungus, what have you, a foreign invader, your immune system needs to identify it as a foreign invader and beat up on it. And at the same time, your immune system needs to make sure not to attack yourself. So my stepbrother is a United States Marine, and I asked him, and he confirmed that you're not supposed to shoot your buddy on guard duty, no friendly fire. And so the immune system's role is really identify self and leave it alone, and identify bad guys and take them out. And the way that it does that, and this is one of the slides that I stole, is through a very complex network. There's really two halves to the immune system. So on the left-hand side of the screen, you see where it says the innate immune system. And then on the right-hand side of the screen, you see where it says the adaptive immune system. And those are the two halves of the immune response. Now, the innate immune system is ever ready. It's always at the ready. It is very, very fast to respond to a bad guy, and it's dumb as a box of rocks. The innate immune system can't learn anything. So conceptually, I sort of think of them as like cavemen, and they're at the ready and they're going to attack whatever they see, but you really can't teach the innate immune system to become more subspecialized. On the right-hand side of the screen, the adaptive immune system is something that you've probably heard about before. This is the humoral and cellular response, i.e. the B cells and the T cells. And the B cells and the T cells, the adaptive immune system, are kind of like college freshmen. When they start off, they don't know what they want to be when they grow up. And they can subspecialize and they can learn very, very specific things. So when you come in contact with chickenpox as a child, your adaptive immune system builds an arsenal specifically against chickenpox. And you have special B cells that are chickenpox B cells. They identify chickenpox. and you have special T cells that identify chicken pox. And you maintain that immunity, those B and T cells, and they float around your body for the rest of your life. So if you come in contact with chicken pox a second time, say in your 20s, your immune system has been waiting and since you were 12, and that B and T cell response jumps all over it. And so the innate and the adaptive immune system is part of this operation in your body to fight off foreign invaders. This is going to become very, very important as we start to understand MS as an autoimmune condition and what you need to know so that you can help make very, very informed decisions. As a sidebar, why are they called B and T cells? It has to do with the way that they grow up. So T cells are born inside the bone marrow, and when they leave the bone marrow, they go to school. I like to call that T cell university up in the thymus. And because they go to school in the thymus, they're called T cells, T for thymus. B cells, when they're born in the bone marrow, but they stay in the bone marrow and they grow up in the bone marrow, and B for bone marrow. So just in case you're playing Scrabble, you've got a couple extra thoughts there. Now, I want you to put a pin in the idea of the immune system. And I want to shift our attention to an autoimmune condition, multiple sclerosis. And when I am in clinic, I want my patients to be 5 for 5 in their fight against MS. There are 5 clinical things that I want them to be doing at all times so that they can live their very best life despite having MS. The very first one is to not smoke stuff. Why do I say that? Because smoking speeds up multiple sclerosis by nearly 50%. It's the most modifiable risk factor. If you have MS and you smoke, you're speeding up your disease, unfortunately. And if you quit smoking, you slow the disease down. Moreover, any unchecked cardiovascular risk factor, so that is to say, if you have diabetes that's not under good control, if you have high blood pressure, which we're not controlling, if you have high cholesterol that we're not controlling, any of these things can help speed up your disease process. And so when I want you to be 5 for 5 in your fight against MS, I want to start by you not smoking stuff. The second thing that I need us to do to live our best life despite having MS is to eat smart. Now, what does it mean to eat smart? It means that we have to give credence to the fact that what you put in your mouth influences the disease process in how well you can live your life. And time again, when my patients clean up their diet, I am shocked and delighted at how much better they fare. When I talk about eating smart, we start off really easy breezy cover girl. I need you to up your water game. I need you to drink 100 ounces of water if you're a gal and 120 ounces of water if you're a guy. MS Water Challenge. Oh, that's really good. And we need to avoid running around dehydrated because that makes a lot of symptoms much, much worse. When we talk about eating smart, I also want you to supplement your vitamin D. Low levels of vitamin D turn out to drive the MS disease faster, and supplementing vitamin D can slow that back down. And so number 2 in being 5 for 5 is to learn to eat smart. Number 3 is to exercise as part of your lifestyle because exercise is one of the least appreciated disease-modifying therapies. You can preserve brain volume, slow down the rates of brain atrophy by exercise. You can preserve the reserve. You can help maintain cognition and improve energy levels and improve mood all through exercise. But as a quick mind exercise, imagine that we cloned you. Now we'd have to get permission from your family and we'd have to make sure they were okay with this experiment. We have 2 of you now. And we give one of you an elliptical and one of you daytime TV. And so I've got a version of you that is exercising as part of your lifestyle and a separate version of you that's watching TV and not exercising. And we get back together in like 5 years. The one that was on the elliptical is in ship shape. I've got a Greek goddess of sorts with a strong core and great lungs, great balance, cardiovascular endurance is on point. Then I've got another version of you that found the weight that the first one lost, and they have a weak core and they're not in great shape, but boy, they know everything there is to know about television. And we cause an attack of left leg weakness, which affects both clones. The first clone, who we prehabilitated, is limping around, getting along with life. And the second clone, who we allowed to become deconditioned, is in a wheelchair. And I'm not going to insult you on the interwebs and say, which one do you want to be? It's a rhetorical question. Suffice it to say that if we are going to live our best lives despite having MS, I need you to exercise as part of your lifestyle. Now, number 4 is the practice of daily mindfulness. I define mindfulness as being in the present moment without prejudice. So doing an activity and not worrying about what you missed yesterday. Doing an activity and not worrying about what's going to happen in the future. I need you to be in the moment. Why? Because stress worsens multiple sclerosis. And I can't stand it when doctors say, oh, honey, just remove the stress, as if we could cut it out. But we can learn to manage stress. And it's my experience that 5 to 10 minutes of daily mindfulness is an outstanding way of helping learn to manage stress. Now, these 4 are important, but number 5 is arguably amongst the most important when I'm asking you to be 5 for 5. And that's to take the most effective disease-modifying therapy that you're comfortable taking. And if we unpack that sentence for a second, taking the most effective DMT that you're comfortable taking takes a lot of work. How do we know if it's the most effective? How do we know how it works? How do I know if I'm comfortable taking it if I don't know the safety and the tolerability? My point here is, in order for you to take the most effective DMT that you're comfortable taking, it requires a tremendous amount of education. And what I was hopeful that I could do with you guys during this lecture is I want to up your game, and I want to talk to you about some exciting new therapies that are coming down the pipeline. I want to help educate you to familiarize yourself with some of these new therapies in preparation so that you can have meaningful and engaged conversations with your neurologist about future therapies. And so with that preamble, I'm going to spend a few minutes talking about some emerging therapies. The first that I'll be discussing are called biosimilars. The second that I'll be discussing are bruton tyrosine kinase inhibitors, or BTK inhibitors. And these are therapies that are not commercially available today, but they are coming very, very quickly. We will probably see biosimilars hitting the market within the next year or so, and we will probably see BTK inhibitors hitting the market probably in the next 2 years. And so I want to give you some information about these therapies so that you can prepare yourself, so that you can help answer the question about taking the most effective DMT that you're comfortable taking. So jumping in, let's start talking about biosimilars. Now, we can't talk about a biosimilar unless we first define the term biologic. So what exactly is a biologic? A biologic is a medicine which was created from a living source. So a living source, for example, it's a medicine which is made by human cells or by animal cells or by bacteria. It's a biologic substance, and it's administered to patients either through a shot or through an infusion. The reason is because biologic substances made of proteins and sugars degrade if you put them in your mouth. So if you took a biologic agent and you swallowed it, it would dissolve in your stomach the way that steak would dissolve in your stomach. Now, as you look at the slide here, I have 3 examples of MS medicines on the screen. On the left-hand side, I have teriflunomide, codename for Aubagio. And teriflunomide is an example of a small molecule. And you can see in the center of the screen there that little itty bitty tiny chemical drawing, and that represents teriflunomide. So teriflunomide is an example of a small molecule. These are chemicals oftentimes given as pills, and there's lots and lots of medicines that are small molecules. If you look in the center of the screen, here we have an example of glutathione acetate, a code name for Copaxone. And this is a non-biologic, but a complex structure, all right, a complex drug. It's not a biologic, but it's also not a small molecule. It's chemically synthesized, just like small molecules. So you make it with a laboratory. It's not with a living substance. And it's oftentimes complex amino acids. And so here, the shot glutathione acetate is an example of a non-biologic complex drug. Now, on the far right-hand side, here is an example of a biologic agent. All right, rituximab, which is a off-label monoclonal antibody used to treat multiple sclerosis, is a biologic agent. It's created in mammalian cells. All right. So we make mammalian cells make this antibody. And it's very specially engineered so that it has a very specific purpose in the human body. It's an antibody. All right. So our bodies make antibodies, but as an example of a biologic, we can create antibodies in mammalian cells in a laboratory. And just to give you an idea, so monoclonal antibodies are some of the most effective drugs that we have available to treat multiple sclerosis. I want you to direct your attention to that word rituximab. See, so rituximab, if you read it backwards, it actually tells you what the molecule does. So let's just do that really quickly. So the last two letters, AB, stand for antibody. An antibody is like a biologic key because rituximab and other monoclonal antibodies are very, very specific. So if I had a key that I was showing you here, this key hypothetically would only unlock one door. So if I put that key to my house and my front door, it'll unlock it. It's specific to my front door. But if I took that same key and I went over to my neighbor's house and tried to open their door, it wouldn't work. And antibodies are specific. They have very, very specific binding sites. The letter M that you see there in rituximab stands for monoclonal. So what they do is in mammalian cells, they make not one Rituxan antibody, but they make millions and millions and millions. And when you have a bag of a monoclonal antibody like Rituxan, it's millions of copies of that exact same biologic key, that antibody. Now, the next two letters, XI, tells you that the way they made this was chimeric, that it has protein in it that is both mouse and then other parts that are human. And if you look at the next two letters, TU, it tells you that this drug was initially invented to treat a tumor target, but we found its use in things like multiple sclerosis. And so I simply present to you a monoclonal antibody as a very good example of a biologic agent. Now, what exactly do we need to think about biologic agents before we can start to talk about biosimilars? You might not know this, but when you make a biologic agent, you make it in a batch, kind of like when you're making soup. So when you're making soup, you're making this vat of soup. And when you're making a biologic agent like a monoclonal antibody like rituximab, you literally make it in a batch. And I was surprised when I first learned this next fact. Batch to batch, there is variability. So when your mom makes her famous chicken noodle soup, it may be slightly different each time she makes it. Now, of course, it always tastes delicious because it's mom's soup and you can identify it as your mom's soup, but it might have slightly more spices or slightly less salt or a little bit more chicken. Batch to batch, it's going to be different. And when you're making a biologic agent like a monoclonal antibody, there are very small differences from batch to batch. Okay, so that's a preamble about biologic medicines. Now I want to shift our discussion to something which is not new in medicine, but it's new in multiple sclerosis, and that's the advent of a biosimilar. A biosimilar is a biologic medicine which is made in a human model, and it's extremely similar. It's very, very similar to a different biologic agent that has already been approved. So we would call the original biologic agent the reference medicine or the innovator medicine. That's the first one. And then we would call the biosimilar, the one that's very similar to it, that's the biosimilar. And as I'm going to share with you, when you have a biosimilar, it has to go through very, very rigorous testing to get it approved. Now, before I jump into that, I just want to jump back to this slide for a second. When you have a medicine like on the far left, teriflunomide, and you have a branded molecule like Aubagio, and you're allowed after a while to make a generic. When they make a generic small molecule, all you have to do is you have to show that the chemical structure of the small molecule matches the chemical structure of teriflunomide. You do not have to test a small molecule in humans. And to be honest, as a human doctor, that bothers me. Because what that means is when we're testing a generic small molecule, it has never been tested in a human being. And that doesn't sit very well because that means that I'm going to be giving it to a patient and I don't know whether or not, just because it looks alike, whether it's going to be the same. This is not the case when you're dealing with a biosimilar. And as I'm about to share with you as an example, biosimilars go through a very rigorous set of criteria in order to be approved. Now, this slide helps you understand the development of the reference biologic. That's the cartoon on the left. And then I'll talk about how we develop biosimilars on the right. So please direct your attention on the left side of the screen to that upside down pyramid. And the way that we're going to read this pyramid is from the bottom going up. And this is really the way that we develop biologic agents. And so I gave an example a second ago of rituximab. They start off at the bottom on the left there with analytical characterization. In other words, what are the amino acid chains and what's the structure of this antibody that we're trying to develop. And after they've done a little bit of work in analytic characterization, the next step is preclinical testing, where we would test that antibody, but we're not going to test it in a human just yet. We may test it in a mouse, we may test it in a monkey, but we're going to do some preclinical testing, clinical meaning with humans. Next, as you go up, we see PK/PD, which stands for pharmacokinetics and pharmacodynamics. Now, those are doctor words for starting to understand the way the medicine behaves in the human body. And then lastly are some very hardcore clinical studies. So I, as an MS neurologist, have made it a big portion of my career participating in clinical trials where a biologic agent has gone through those steps of analytic characterization, preclinical, PK/PD, and now we're going to test the drug in people impacted by MS. And if we test the drug and find that it is effective and that it is safe, it can be FDA approved. Now, once you're done that process, we're going to call that the reference biologic. And if you now turn your attention on the right-hand side of the screen, I'm going to walk you through the differences when you develop a biosimilar. It starts at the bottom and it goes up. So on the right-hand side, we start at the bottom. And what you see is the first thing that we do is analytic characterization, but we do a lot of it. Why? Because we don't know the exact recipe for the biologic reference arm. Your mom will not give you the recipe. And so you don't know exactly how much goes into that batch. And so there's a tremendous amount of study going into characterizing and building a molecule that is as similar chemically to the first one as possible. And after we get the structure and we think we have developed a monoclonal antibody that is very, very, very similar to the reference arm, we go up to preclinical testing. And we're going to test this new biologic agent, this biosimilar. We're going to test it in non-humans to make sure that it appears safe. We're going to do PK/PD testing, and then we are going to do a phase 3 clinical trial. Now, this is not a gigundous trial the way that we do with the reference product. It's a smaller clinical trial, but we're testing the molecule in human beings, which is very meaningful to me. And I'm going to use an example of a biosimilar that was just developed, and we will see this in MS. And this is a biosimilar for one of the monoclonal antibodies called natalizumab. And natalizumab, the branded name is Tysabri. And so many of you are familiar with Tysabri. It's a monoclonal antibody which is given through the vein. It's infused once every month, and it's been FDA approved for MS since 2004. And today, natalizumab remains one of the most effective medicines that I've ever used in clinical practice to treat MS. Well, interestingly, a company has successfully developed a biosimilar natalizumab. And what you see on the screen here is sort of the pathway that they did it. So walk through it with me. Start at the very bottom again with the analytics. And they needed to make a molecule. They needed to make a monoclonal antibody, which was very, very, very similar to the Tysabri natalizumab. It had to have all the same amino acids and the same structure. They needed to make sure that it looked as close as they could make it. And then as you go up a notch, they took that new antibody, the biosimilar, and they tested it in monkeys. And then when you went up a notch, they did a phase 1 study in human beings, healthy controls, not people with MS. And they looked at the way the molecule behaved in the body to make sure that it behaved the same as branded Tysabri. And then lastly, they did a proper phase 3 clinical trial. where they tested this in humans with MS. And I'm going to talk a little bit more about that. Now, this slide makes the point that the molecule, the biosimilar, is behaving exactly the way that Tysabri behaves in humans. And what you see actually is three different lines. There's a black line, which is the biosimilar natalizumab that's being developed. There is a blue line, which is Tysabri from the EU, from Europe. And there is a red line, which is Tysabri, a batch of Tysabri from the United States. And what you see here is a pharmacokinetic linear plot. In English, Aaron, when you give someone the drug, what's the blood concentration and how long does it take for that blood concentration to die down? And when you start to put the three on top of one another, what you find is the biosimilar acts identical to the batches of Tysabri made in the EU and to the batches of Tysabri made in the United States. And so this, if you go back to my graph here, is that second to top one, the pivotal phase 1 PKBD. We know that we're on to something. And now it's time to do a proper phase 3 clinical test. Now, the clinical trial was named the Antelope trial, and I actually don't know why it was called Antelope, but that's kind of cool. And in this clinical trial, people with relapsing multiple sclerosis, in fact, 263 people, entered into the trial. And they were randomly assigned to either take the branded Tysabri, that's the reference natalizumab, the drug that's been out since 2004, and that's represented here in green, or they were given the new biosimilar, which is represented in gray. And so you had about 130 patients in each arm, and for about 44 weeks in total, they participated in this trial where they took the medicine and then we observed the patients, keeping track of their exams, of their attacks, and of course, getting MRIs. And at the end of the trial, it allows us to then compare clinically how the two different drugs did. Now, what you see on the screen here is looking at the MRI and specifically looking at new spots that showed up on the MRI over the course of the nearly 2 years. And what you can see is in the blue dots, that's the biosimilar that we're studying, as compared to the orange dots, the Tysabri, that they literally almost overlap. And we do not see a statistically significant difference in the number of new spots that developed on the MRI, one drug versus the other. So this is data in real human beings with real MS, looking at real Tysabri, the reference natalizumab, as compared to the new biosimilar. And this data is extremely reassuring to me, at least to know that the MRI is going to behave the same with either biologic. Now we turn our attention to clinical trials data, looking at things that matter in clinic, like your disability score and your relapse rate. So on the left, we see the EDSS score. So the EDSS, which stands for the Expanded Disability Status Score, is when we take a neurological examination, when we do the MS Olympics, and then we turn it into a number to talk about the degree of neurological disability. And this was done with all the patients in the trial. And you see the biosimilar that we're studying in blue, and you see the reference natalizumab, in other words, Tysabri, in gray. And whether you look at the beginning of the trial at 24 weeks or at the end of the trial at 48 weeks, the disability scores were the same. Statistically, they were exactly the same. And that is also very reassuring. When you look on the right-hand side of the screen, we look at the relapse rate. So how often are people in the trial having an attack? And what you can see is that the biosimilar natalizumab had about the same number of attacks as the reference Tysabri. And so when you consider the data on this slide, looking at the MRI, when you consider the data on this slide, looking at the disability accumulation and the relapse accumulation, we now can feel increasingly confident that whether you're taking the reference natalizumab, that is to say branded Tysabri, or the new biosimilar, that it's behaving the same chemically, and it's resulting in the same number of new spots and new attacks. Now, before we leave the topic, you also, of course, always want to know when you're thinking about a drug, not just the efficacy, but the safety and tolerability. And so the question was asked, Is the safety of the biosimilar the same? And the answer is, fortunately, yes, it is. And what you see here, the BP006, that's the biosimilar that's being developed against the reference natalizumab, that's the Tysabri arm. And TEAE stands for treatment emergent adverse events. In other words, bad things that happen during the trial. And you see that statistically, it's about the same. And when you look down at the second to last line, events that led to people leaving the trial, it was slightly higher, a couple people more in the biosimilar than Tysabri, but by and large, it was similar. And again, we have to keep in mind, these are very, very small numbers. So my take from this slide is that not only is the pharmacokinetics the same, not only is the MRI the same, not only is the relapse rate and disability progression about the same, but the safety profile is the same. Now, why is this so darn relevant? It's relevant because we will soon see biosimilars such as this entering into the market. And this is not a generic medicine from a small molecule. This is rather different. And it's my hope that by using this example, I can help give you some information to help you think about biosimilars and biologics in general. Again, my goal here is to up your game so that when you and your neurologist, maybe in the future, talk about a biosimilar, you have a better understanding of what it means and what it doesn't. And so I'm now going to turn my attention to a second group of medicines, which is catching a tremendous amount of excitement, the BTK inhibitors. Now, I have to tell you that when I first heard about BTK inhibitors, I came home and I said to my ex-wife, hey, I'm going to be doing a clinical trial with BTK inhibitors. And she said, oh, bind, torture, kill, which completely freaked me out. I said, what? And it turns out, although I didn't know this, that there is an American serial killer called the BTK killer. And I want to assure you that this has absolutely nothing to do with that whatsoever. That really, really weirded me out when she taught me that. In fact, she made me watch a scary documentary on the guy. So that's not what we're talking about today. Today, we're talking about a small molecule, Bruton tyrosine kinase inhibitors. These are pills. These are not biologic agents. They are small molecules. They're chemical molecules. They've been around for a very long time to treat cancers. And it turns out that they seem rather amazing in MS. So at the Boster Center for MS, we're doing 5 clinical trials looking at BTK inhibitors. And worldwide, there is a tremendous effort in developing BTK inhibitors to treat MS. And I want to explain why we're so darn excited about it. When you think about the drugs that are currently available to treat MS, it fills me with pride that we collectively as a community have developed 27 different formulations of 19 different medicines to treat MS. But most of those, actually all of those medicines only work on the adaptive immune system. Remember in the very beginning slide, I showed you the innate immune system and the adaptive immune system. And I said the adaptive immune system was the B and the T cells. All of the drugs that you're familiar with to treat MS work on the B and the T cells. None of them directly work on the innate immune system. And we know that the innate immune system is involved in multiple sclerosis. And so ideally, we want a medicine that can work on both the adaptive and the innate immune system. The second thing to keep in mind is all of the MS medicines that are currently FDA approved work in the periphery. They work in the bloodstream. And the problem is in the brain. And so it would be wonderful if we could develop a molecule that worked inside the central compartment. Now, one of the reasons that I'm so darn excited about BTK inhibitors is they do both of those things. We're going to talk about that now. Now, this slide that I ripped off the internet is a cartoon of the central nervous system on the right. That's the gray. So that would be like inside the brain. And then the pink on the left-hand side, this is the bloodstream, the periphery. And so as we've talked about, the immune system is out in the periphery and it can cross that blood-brain barrier and get into the central compartment. And there are immune problems with MS in the periphery, and there are immune problems with MS in the central compartment. And specifically, we're very concerned about B and T cells in the bloodstream, in the periphery. And you can see the T cell has that green color, and the B cell in this cartoon has a blue color. And you can see that they're in the bloodstream, in the periphery, and then they can cross into the central compartment. And these, unfortunately, in the setting of MS, are naughty B and T cells that want to attack the brain and spinal cord. And if you look inside on the gray area, you see some cells that are part of the innate immune system, the microglia in specific. Microglia are cells that live only in the brain. They never leave the brain, so they're in the central compartment. And when they're happy, they just kind of chill out, and they keep everyone happy, and there's not a lot going on. But when they get mad, they literally turn into the Incredible Hulk, and they start to eat things they're not supposed to, like your brain. And I'm going to share with you over the next couple slides how BTK inhibitors work on the periphery, on the B cells in specific, and they also work in the central compartment on microglia, which is pretty darn exciting. So here we're going to focus our attention on the impact of BTK inhibitors, although I noticed that I spelled that wrong. So sorry about that. It's not BKT, forgive me. So BTK inhibitors and their impact on lymphocytes, specifically on B cells. So B cells are very, very involved in multiple sclerosis. And many of you are aware that there's a lot of medicines on the market which deplete B cells. Earlier in this talk, I gave you an example of the medicine rituximab, which murders B cells. Ocrelizumab, ufatumumab, ublituximab. These are all monoclonal antibodies. They're all biologics, which deplete adult B cells. And when you deplete adult B cells, the B cell can't stimulate the T cell, and therefore the T cell can't attack you. And the result is it slows down MS at a cost. Because as you can see on the slide, B cells do lots of different things, including fighting off bad guys. And one of the problems that we can be faced with when you're using a B cell depleter like rituximab is that it can increase the risk of infection. BTK inhibitors do something rather unique. They do not cause murder. They don't kill the B cell. They simply plug its ears so that it can't hear. So they interrupt B cell, T cell communication by making it so that it can't hear, kind of like, nah, I can't hear you. And they prevent the B cell from becoming active without murder. Now, this is a really cool phenomenon because we can gain the benefit of suppressing B cell function without murdering the B cell. And as a result, we can have an impact on MS without increasing the risk for infection. And so this is one of the things that BTK inhibitors do that I'm very, very excited about. This effect is in the periphery, it's in the bloodstream, and it works on B cells in a very unique way with no murder. Now we turn our attention inside the brain, in the central compartment, where none of the other medicines to date are able to go. And we identify a cell that we've never been able to touch before, and that's the microglia that I mentioned earlier. So a BTK inhibitor, the small chemical molecule, can go from the bloodstream into the brain. It can identify a microglia that's getting all riled up and starting to misbehave and eat stuff it's not supposed to. And it can bind to it and it can stop it from doing that. And that's really amazing. And this would be one of the very first medicines that will be brought to market that has an impact on the microglia, on the innate immune response, and it does it in the central compartment. And so, as you can see, it's a very, very exciting time. Right now, there are several manufacturers that are developing several different BTK inhibitors. And I wrote a couple of them down there for you because I wanted you to see that they all end with the same letters, brutinib. So we have evobrutinib, tolobrutinib, fenobrutinib, and remibrutinib. There's more. But when you see a word that's brutinib, you know that you're dealing with a BTK inhibitor. And these medicines are currently in investigation with multiple sclerosis. The very first BTK inhibitor will get a readout on the data actually later next month. And we're very, very excited for what's coming. Now that concludes the didactic portion of this talk. It's been a pleasure getting to share with you sort of what's coming down the pike and hopefully giving you some things to think about and so that you can have an engaged conversation with your neurologist. I'd love to turn the mic back over to Stuart and answer any questions that you guys have.
All right, we have a question over there on that side of the room.
Yeah, hi. Is there any connection between BTK and the amino acid L-tyrosine supplement?
I would not draw connections between the two. No, I wouldn't put those together. And I love your orange. That's a great color.
Hi, I just want to know, BTK sounds excellent as a therapy, but are there any adverse effects with it along with pregnancy?
That's the most excellent question. So if a doctor ever tells you that a drug doesn't have side effects, simply stand up and walk out of the office, because they're lying, because all medicines have side effects, right? And so part of the process of doing a clinical trial is to characterize what the side effect profile looks like. So I can share with you some information, and as the clinical trials complete, we're going to get a bunch more information on that exact topic, on safety and tolerability. So one of the things that we have to keep in mind is that BTK inhibitors, the pills, are metabolized by your liver. And so there's a risk that it could beat up on your liver. And so we have to check liver enzymes very carefully to make sure that's not a problem. That's one of the things that we absolutely want to keep in mind when we're thinking about BTK inhibitors. Also, rarely BTK inhibitors can interfere with clotting of your blood, and you can have things like easy bruising and things like that. This are two things that I keep in mind because I'm running a bunch of clinical trials with BTK inhibitors right now. Now, more information will come out. I don't think that it's recommended that people become pregnant when they're on MS medicines, including BTK inhibitors. And so invariably, we're going to have some recommendations when we see the labeling about how long we need to be off the therapy before it's safe to conceive. That was an excellent question. Thank you.
Online first. So a person that you know out in Ohio says, "Howdy, Dr. Boster. Will your practice start testing for neurofilament light chain or other biomarkers?"
So that's a fantastic question. And neurofilament light chain is a future hopeful, something that we hope to be able to make prime time. And joked for years and years that the thing that we want in MS is something like a tricorder, like where Bones McCoy from Star Trek could bust open his tricorder like this. I have a patient that sent me a tricorder. So this was the neatest present I've ever been given, where I could scan a patient hypothetically and then figure some things out, right? So we don't have a tricorder like Bones McCoy did in Star Trek. What we have right now from a biomarker standpoint is not amazing. It's clinical history, exam, old school stuff, and then the MRI. Neurofilament light is a blood test which is rapidly being developed and starting to be used in research studies to help assess activity in multiple sclerosis. And we're starting to see it trickle into clinics. I still don't believe that we have all of the reference arms sorted, and I still don't believe that it's 100% prime time for clinic, but my clinic is chomping at the bit nonetheless to get a hold of it. So do I imagine that we're going to be checking neurofilament light a couple times a year? Yes. Do I think that's going to happen in the next year or two? I absolutely do. And that's a great question.
Yes. My first question, what do you suggest for a dosage of vitamin D supplement?
So we have a good sense that low levels of vitamin D drive MS faster, and higher levels of vitamin D correlate with better outcomes, slower brain volume loss, less spots, less attacks, good stuff. And so supplementing vitamin D is really, really important. And the way that I want to dose vitamin D is based on your blood level. So I can test a simple blood test called a vitamin D 25-OH level, and I can get a number. And the numbers range anywhere from the teens up into 100. And anything above 50 is where I want you to be. So between 50 and 100, that's exactly where I want you to be. Less than 50 is not so desirable. And so what I typically do with patients at the Boster Center is I check blood during the winter months when the vitamin D is going to be at its lowest. And I want that number to be above 50. And if it's below 50, then we need to use some supplementation. Now, most oftentimes here in Ohio, that translates to taking 5,000 international units of D3 because D3 is better absorbed in the human body. And we do that once a day. Or we'll give people 50,000 international units of D3 taken once a week. Now, again, I'm not saying go out and buy 5,000 and take that every day. I think we need to check blood levels, but most commonly, those are the doses that we use.
Hi, Dr. Boster. So which types of MS will the BTK inhibitors be used for? Is it primary progressive? Is it which type is it going to be useful for?
So that's an excellent question. And we are very hopeful that because these medicines impact the central compartment and because these medicines impact microglia, that we have a strong chance of slowing not just attacks, but also progression. So right now at the Boster Center, we're doing clinical trials with BTK inhibitors that are testing relapsing remitting multiple sclerosis, separate trials looking at secondary progressive multiple sclerosis, and separate trials looking at primary progressive multiple sclerosis. So the future is very, very bright, and we are very hopeful that there may be applications across all types of MS.
Great, thank you. Next one from online. Is a biosimilar less expensive? And what would the point be of making a biosimilar of an already existing medication?
So for example, the natalizumab biosimilar that I presented to you today, I don't know pricing on that. Theoretically, it should be less expensive than the branded drug. And so biologic agents, as you can imagine, are extremely expensive. Monoclonal antibodies are very, very expensive. And so it's our hope that by developing biologics that are biosimilars, they're less expensive and they're more available to more people. And so both of those things are very, very important. And I think that's the way we'll see it play out when these drugs hit the market. Our anticipation is that they're going to be less expensive than the branded ones. Great question.
Hi, doctor. You said that the research between both the biosimilar and Tysabri are very close, right? So the
Yes.
responses. So what's the advantage of the biosimilar to the actual drug? And the other thing is, what are your thoughts about stem cell that they are returning the research again, right?
So two great questions. We'll take them in order. So why bother making a biosimilar? Really, one of the reasons that we want to make a biosimilar is so that more people have access to the medicine. And as I mentioned in the last question, hopefully it's less expensive, and which makes access even better. And so having more options is important. And this is an option which we hope will make natalizumab more available to more people at maybe a lower cost. Now, the second question has to do with stem cell transplantation. And stem cell transplantation is not a drug. It's not a medicine. It's a procedure. It's a procedure which is pretty hardcore, where we take cells out of someone's body and then we murder the human. We give them lethal doses of chemotherapy, which if we didn't further intervene, they would die from a simple cold. Very serious. And before they succumb, we give them back the stem cells and so that they don't die. And by removing their immune system, we hopefully remove some of the autoimmunity. Now, stem cell transplantation is not a cure. It does not cure autoimmune conditions, but it can be very, very helpful in treating super aggressive autoimmune conditions. And it's actively being studied in the setting of multiple sclerosis. It's my strong opinion that stem cell transplantation is a very exciting research endeavor, but that it's not prime time yet. I do not think that in the United States that we should really be doing stem cell transplants outside of proper clinical trials. Now, you can travel to exotic locations like India, Russia, Mexico, Chicago, and you can find people to do stem cell transplants, but I do not recommend doing that outside of a clinical trial. The data is becoming more and more encouraging. So for example, in Great Britain, for very aggressive MS, the NHS now makes stem cell transplantation available. And I think that the United States will probably follow suit in the next couple years. Stay tuned. With every new Congress, we hear more and more exciting information about where the field of stem cell transplantation is taking us.
Are there any correlations with gallstones or kidney stones with DMTs?
So that's a great question, because you don't live in isolation with just your immune system, right? So your immune system and all the other systems in your body are subjected to drugs when you take it. So I am not familiar with problems specifically with gallstones associated with any of the MS medicines. Now, that doesn't mean that someone who is prone to gallstones might not be aggravated by one drug or another, but off the top of my head, fortunately, no. I don't know of anyone where it's a no-no and on the naughty list.
Tell us about osteoporosis and MS, or about bones that don't properly heal for those with MS.
Yep. So sometimes nature's a little too generous. And as it turns out, that people impacted by multiple sclerosis over the age of 50, which is not old, have an accelerated bone thinning. So both men and women with MS, completely independent from steroids, are at risk of having thinning bones after the age of 50. And so we have some doctor words that we use. Osteopenia, that's a Scrabble word. Osteopenia means thin bones, and osteoporosis means very thin bones. And people over 50 with MS are at risk of both. And this is very, very serious, because people impacted by MS are also at risk of falling. And so you can imagine a bad situation where a 50-something or a 60-something with MS has thinning bones but doesn't know it, and takes a tumble and shatters a hip, God forbid. And so it's a best practice that people impacted by MS over the age of 50 have bone density testing. This is where literally we measure the thickness and density of your bones. And if we identify that, in fact, you do have osteopenia or osteoporosis, we can do things to beef them up. Stomping the ground, doing physical activities where you're pounding on the ground, or doing weightlifting activities where you're putting your bones under pressure can cause reactive bone growth. We can supplement your calcium intake by taking calcium supplementation. Vitamin D and vitamin K2 help push the calcium into your bones. And there's even medicines like Prolia, which we can give to people to help further force calcium into the bones. And so it is a best practice, in my opinion, as you help people impacted by MS, particularly those over the age of 50, to make sure that we're monitoring their bone densities every couple of years and treating accordingly when necessary. That's a really important question, Stuart. Thank you.
Thank you, Doctor. Doctor, it's great news on the BTK inhibitors. But one of the questions I get is, you said slow down. It will slow if it works. Thank God. How about remission? You think you would ever be in a position where you'd have either go away or have full remission?
So let's define the word remission. It's a very appropriate question, sir. I like the oncologic definition for remission. So in oncology, in cancer world, they define remission as follows: 5 years of no disease activity in the absence of treatment. So that's how we define remission. And I think that we can apply that same definition to multiple sclerosis. So when you take a continuous therapy, any continuous MS therapy, whether that be a monthly Tysabri or a daily Aubagio or whatever the case may be, and you have quiet disease, that's a godsend, but it's not remission. It's just very successful treatment. There are some MS medicines which are discontinuous, like alemtuzumab, codenamed for Limtrada, or Mavenclad, codenamed for cladribine. And these are discontinuous therapies that reboot the immune system. And I can tell you that I have some patients that have received these therapies, and once you take them, you don't retake them, and they've gone out more than 5 years, and they haven't had any disease activity. And with tears in my eyes of joy, I have written in the chart, in clinical remission. Now, keep in mind, being in remission does not mean a cure, all right? And the disease could come back and rear its ugly head, but it's very, very exciting to me that in my lifetime, we are starting to identify some people that actually are meeting the oncologic definition of remission. Now, specifically as it relates to BTK inhibitors, these are molecules, these are pills that you take once or twice a day, every day. And it's my hope that they can make the disease very, very, very quiet, but it wouldn't meet the definition of remission because we continue to take them. Very good question. Thank you.
Hi, how are you? Thank you for your talk. It was very informative. I have a question. I'm a primary care PA, and obviously I counsel my patients not to smoke cigarettes, but when you said don't smoke stuff, I have a lot of patients with MS who smoke cannabis, and without being political, in Florida, it's legal for medical cannabis for multiple sclerosis. Does that also speed up disease activity, or are we just talking nicotine-containing substances?
I am delighted that you picked up on that. I had that sentence crafted very carefully. I said, don't smoke stuff for a reason. And the reason is exactly what you just talked about. So in the great state of Ohio, I am a medical marijuana recommender, and I am a big believer that cannabis can help with many symptoms in MS, but I don't want you to light it on fire and suck in the smoke. When you take a carbon-based material, whether that be dried out tobacco leaves or dried out cannabis leaves, and you light it on fire and smoke comes billowing off, and then you suck in that smoke, that's super, super pro-inflammatory. And so, whereas I oftentimes recommend medical cannabis to help patients with anxiety and with insomnia, with spasticity, with pain, I don't want them to smoke it. I recommend that they use an edible, like a CBD gummy or a THC gummy, or a tincture, or topical, or if they have to have a fast onset of action, I feel like a vape pen, which does not heat up the molecule above the level of combustion, is probably a little bit less pro-inflammatory. So thank you for your attentive ears. You picked up on that. That's exquisite.
Thank you very much. Next from online, person writes, currently, Ocrevus is the only approved DMT for PPMS. Do you anticipate that either biosimilars or BTK inhibitors will have efficacy for PPMS?
I am very hopeful that BTK inhibitors will work in primary progressive MS. And I'm very proud that at the Boster Center, we're currently doing a clinical trial called the Perseus trial, which is studying BTK inhibitors in people with PPMS. And at my center, we have several very, very brave human beings with PPMS that have volunteered their bodies to try to answer that exact question. So the data is not out yet. We're still doing the trial, but soon to come. And fingers are crossed.
Okay, thank you. Also from online, have there been any long-term clinical studies about the effectiveness of current disease-modifying therapies preventing disability for secondary progressive MS?
The answer is yes. And so there's been several studies looking at whether or not we can slow down multiple sclerosis in very which ways, including slowing down the onset of secondary progressive MS and slowing down the progression in secondary progressive MS. And there are products that can do that. For example, in alemtuzumab, Limtrada, there's good evidence that we can delay the onset of SPMS. For example, in Tysabri, a drug that we've talked about a few times this lecture, we can slow down the worsening arm function associated with secondary progressive MS. So we're starting to be able to scratch the surface. It's not perfect, and we need to do better, but the drugs that we have available today can have some impact. And it's my hope that the drugs of tomorrow, the stuff I talked about in this lecture, may do an even better job.
Thank you. Next, will they give BTK inhibitors to long-time MS patients and or those over 65?
So that's an outstanding question. When we do clinical trials, we generally do not test people that are under the age of 18 because we don't do the experiments in children. And generally, we don't test them in folks that are over 55, which bothers me because plenty of humans with MS are older than 55. Now, one of the things that I think is delightful with the BTK inhibitor trials, particularly the trials looking at SPMS and PPMS, is they've extended the age into the 60s. Maybe not 65, but we're going 58, 60 years of age. And so we're starting to study in a slightly older population. Do I think that these are just for folks when they're first diagnosed with MS? Absolutely not. And when you look at the patients in clinical trials right now for SPMS and PPMS, many of them have had MS for quite some time. And so I'm very hopeful that BTK inhibitors will, in fact, have a place both early in the disease and later in the disease. Now, even though we're not testing BTK inhibitors in 65-year-old and up, I, as a clinician, am able to make a decision, a shared medical decision with the family, and I fully intend to offer it to patients agnostic of how old they are.
Hi, I wanted to ask Doctor, what is the risk of PML in BTK or the medicines that are coming? And how would you transition to them?
So let's first talk about the biosimilars. So we're all familiar that if you have been exposed to the JC virus, and if you take natalizumab Tysabri, there's a very small risk of PML, right? But it's a very scary infection to have. And so one of the things that was studied in that clinical trial that I referenced, the Antelope trial, where they looked at the biosimilar natalizumab, is they looked at risk of PML, and there were no cases of PML with either of the two groups. And it appears that the safety as it relates to PML is the same. They looked at the JC virus titers, the levels, and they were the same in both groups. And a part of the trial that I didn't talk to you about because of time was that some of the people that were on Tysabri were then switched to the biosimilar. And there was no uptick of safety when they did that. Now, the numbers are very small, but it's extremely encouraging to make me believe that the PML risk is probably not increased with the biosimilar as compared to the reference molecule. Now, as it relates to BTK inhibitors, we don't see a high risk of infection with BTK inhibitors. And whereas I would never say never, I think that it's very, very unlikely that we would have concerns of PML with those molecules.
Okay, next. Tell everybody the difference between them having an MS and having a ramped up immune system versus somebody that has a suppressed immune system.
Multiple sclerosis is an autoimmune condition like several other autoimmune conditions like lupus, rheumatoid arthritis, Crohn's, childhood diabetes. Those are all autoimmune conditions. In the setting of multiple sclerosis, the autoimmune condition, your immune system is all revved up. It's overly active. That does not increase the risk of infection. So sometimes people misunderstand and they think that just because you have MS, that you have a higher risk of infection, which is false. Someone with MS does not have a higher risk of infection. In fact, some studies may suggest they have a slightly lower risk of infection because their immune system is all jacked up. Now, when you take a medicine for MS, sometimes that medicine is an immunomodulatory drug, which shifts the immune response. But sometimes the medicine is an immunosuppressant. So we give the human an immunosuppressant. Now that can suppress their immune system and increase the risk of infection. But untreated, the person with MS does not have a higher risk of infection. And that's very, very important to keep in mind.
Great, thank you for that. When a patient runs into going to see a doctor, not a neurologist, but another type of doctor, and that doctor says, "Oh, you need to be on all sorts of these medications and whatnot because you are immune suppressed." What can the person do? I mean, there are a lot of people that just believe that doctor and say, "Oh, I must be immune suppressed, so my neurologist was evidently wrong because my primary says otherwise." How do we tell the primaries that they are incorrect?
So Stuart brings up a really important situation. Doctors are helpers. So I'm a helper, right? I'm trying to help you live your best life. And I specialize in multiple sclerosis neurology. So I'm going to try to help you as it relates to your MS. You probably have several other doctors that do other aspects of care. For example, the primary care doctor. And so you may have two doctors that are both trying to help you live your best life. And sometimes the doctors might not agree with one another, which is a very uncomfortable situation to be in. And you, as a non-doctor human being, you need to not get in the middle of two people that say something that's a disagreement. So if your neurologist tells you something and the primary care says something and it's not in alignment, I recommend that you have the two of them talk. Right? You don't want to get stuck in between two subspecialists. So let's say that your neurologist says something to the effect of, you do not have an increased risk of immunosuppression, and the primary care says, yes, you do. Well, it's not your job as the human, as the patient, to sort that. What I would do is I would say, doctors, here are your phone numbers. Now have a conversation and talk to one another and figure it out. And through dialogue, we should be able to sort that.
Thank you for that. Person writes, I was on Ampera for 16 years and changed to generic, and I not feeling great anymore. How do I get back onto the brand medication?
So this unfortunately can happen because, to our earlier discussion, generics are not tested in humans. And just because the generic molecule looks like the original doesn't mean that it's going to behave the same. And all too often in my clinic, I've experienced exactly that, where we are doing great on branded Ampera, and then we switch to a generic and it doesn't work very well. Fortunately, there's a way to address that. You tell your doctor, and your doctor writes a letter to the insurance company which says, hey, insurance company, the generic doesn't work, switch them back. Love, doctor. And the insurance company will have to honor that because the person's not responding to the generic medicine they were given.
Thank you for that. Next person wants to know, what is a healthy drink that they should be consuming each day?
I'm a big fan of water. So I recommend that the healthiest drink that you could probably consume is water. Sometimes people don't like to drink water, and so we can do things to trick you into enjoying it a little bit more. For example, I like carbonated water because it makes me feel more full, and I kind of enjoy the taste. You can sometimes put things like Mio in the water to change the taste of it. What I would prefer that you not consume is soda pop and sugar beverages and diet sodas and things like that. I think if you're going to have a beverage, I think water is probably your best bet. I also think tea and coffee in moderation are not to be underappreciated.
Great. Thank you for that. So far, are you aware of an increase or decrease association of PML with any of the new MS treatment options?
I am not familiar with an uptick of PML risk with the new treatment options, not at all.
Is there any downside to any of the new treatment options or what you're doing with BTK?
So really, Stuart, that's a difficult answer to provide because the BTK molecules are not done being investigated. We're not done with the clinical trials. And so we're still literally learning what the side effect profiles look like. That biosimilar that I talked to you about earlier was tested in the Antelope trial in a very small trial. And so we don't have large numbers. And so when the BTK inhibitor trials finish, we're going to know a lot more. And when the biosimilars hit the market and more people go on them, we're going to have a lot more information. So stay tuned.
Great. Thank you for that. And the last question that I have for you is for you to tell us your opinions of smoldering MS.
Absolutely. So smoldering MS is a topic which is catching on within the MS community. And I'm talking a lot about like MS clinicians, like practitioners. And it's really calling out something which is a truth that we have not been forthcoming to date with. All right, what am I talking about? People impacted by MS can get worse one of two ways. They can have an attack, God forbid, and not fully recover. So I'll use an example of an optic neuritis where you go blind in your left eye, and when the vision returns, it doesn't fully return. So maybe now you can see some, but you can't read. You have accrued neurological disability. And we call that RAW, R-A-W, relapse-associated worsening. And that's one of the ways that people impacted by MS can get worse. But it's not the only way. There's another way that people impacted by MS can get worse. And that's called PIRA, P-I-R-A, progression independent from relapse activity. And this is a situation where you can get worse independent from attack, independent from new spots. Stuart, I can't tell you how often a patient expresses frustration having seen one of their doctors, and the doctor says something like, honey, you're doing wonderful. You haven't had any attacks, and your MRI shows new spots. You're doing great. And the patient says, well, then why am I having more trouble at work? Well, then why can't I walk as far as I used to? Well, then why am I having these difficulties? And at times, the patient can almost feel like they're gaslit, like the doctor's not listening. And I think calling into scripture the concept of smoldering MS is really being honest about the fact that it's not just about attacks and it's not just about new spots. It's also about the slow burn, the smoldering aspects of MS. And it's important not just because it's honest, but by calling it out and by identifying and talking about it, we can develop research programs to beat it. And so I'm actually very, very enamored with what's happening in the field right now in calling into scripture this concept of smoldering multiple sclerosis.
Great. Thank you for that. Now, I was going to have that as my final question, but somebody just brought this to me, and I want to make sure that I ask this as well. Do any of the osteoporosis medications act on the immune system or shouldn't be used with or within MS patients?
So I have not found an osteoporosis medicine which is contraindicated in MS patients. Some of the medicines are pretty potent. For example, I mentioned the drug Prolia, and I don't like to give a Prolia shot on the same day I give an MS infusion. And so I can give a patient both. I just don't give both on the same day. But it's not a no. It's just planning the timing is important. Good question.
Thank you. But you were talking about Prolia, but what about the other ones? I forgot what they're all called, but you also have Fosamax. And how is that given or not given when somebody gets like Tysabri at the same time?
So I think, I guess what I would tell you is there's ways of sorting all of that out, but it's going to get into very specifics about you as a human being and the other medical ailments that you have and the other medicines that you're on. The take home that I would like to leave you with is we can find a medicine for your osteopenia that will work with your current medicines and with your current MS. Now, we might have to be creative. We might have to do one versus the other, but we'll be able to get it done. The important thing is to remember that we are at risk of thinning bones, that we can check it with a bone density scan, and there are medicines out there which can help beef them up.
Thank you for that. Now, as when Dr. Boster came online, let's say thank you and give him a round of applause.
Thank you, guys.
You're not here for me to give your certificate. All the other doctors were giving this to me, by me today. And so, yes, now you can see it, all right? So I will make sure to get this out to you, or when I see you next, I will just bring it with me, okay? Thank you very much. And Dr. Boster, thank you for getting back to Columbus and making this happen today. We greatly appreciate it, all that you do for the MS community, in local for you and at large and across the United States. Thank you again.
God bless. Have a great day, guys. Thank you again. Bye-bye.
Everybody, thank you very much for coming, and thank you all for being online. Bye-bye.